Hello, good afternoon. Welcome to this Engaging the Mind program. My name is Susan Lynch. I am the Associate Director of Lifetime Learning at the University of Virginia's Office of Engagement. So pleased that you are joining us this afternoon. Before starting the program, I want to bring a few things to your attention. We received many questions in advance of the program. If you have a question during the presentation, you may enter it in the webinar Q&A at the bottom of the screen. You'll also find resources in the webinar chat box at the bottom of the screen. Please also note this program is being recorded and will be posted in Lifetime Learning's podcast library in about a week or two. Please keep in mind that our panelists are unable to answer any personal medical questions or offer specific medical advice during the webinar. Now on to our speakers. Keri Johnson is a board-certified family nurse practitioner who works with stroke patients as part of the UVA Stroke team. Ms. Johnson graduated from UVA School of Nursing in 2012 and later from Vanderbilt University with her graduate degree. Ms. Johnson has worked as a practitioner in the DC area and returned to UVA to work in the UVA health system. We also have Dr. Necrisha Roach, who's an assistant professor of neurology and associate program director in the adult neurology residency program at the University of Virginia. As a vascular neurologist, Dr. Roach specializes in diagnosing, managing, and treating strokes and other neurovascular diseases. After earning her medical degree from Ohio State University, Dr. Roach came to UVA for fellowship training in vascular neurology and has served as a valuable physician here at the UVA health system for many years. So thank you again for joining us for this Lifetime Learning program. Now I'll turn the program over to Dr. Roach and Ms. Johnson, and I invite both of you to start your presentation.
Thank you so much, Susan. We're thrilled to be here to talk about this very important topic. I'm Keri Johnson, the nurse practitioner with our UVA Stroke program.
And I'm Dr. Necrisha Roach, one of the vascular neurologists here at UVA.
So let me go ahead and share our presentation here. Just bear with me one moment. All right, so we'll go ahead and get started. So today we're here to talk to you about strokes. And we really want to run the whole gamut here from talking about what constitutes a stroke risk factor, what happens when one does have a stroke, and what stroke recovery looks like. So today, some objectives we've outlined are to discuss the stroke epidemiology, differentiate between what constitutes a stroke versus a TIA and what TIA really means, go through some stroke risk factors, talk a lot about stroke prevention, how stroke in the young differs from presentations of stroke in older individuals, as well as what life after a stroke looks like. So first, talking about stroke epidemiology. So why are strokes so important? So strokes are the leading cause of long-term disability in the United States, and they're the second leading cause of death in the entire world. Every 40 seconds, someone in the United States has a stroke, and every 3.5 minutes, someone dies of a stroke. And stroke care costs us as a society $56 billion per year. This graphic I have here off to the side also demonstrates a map of the United States and looks at what's highlighted in dark purple, what's called the stroke belt. So it's an area where stroke prevalence is much higher, and we'll delve into that a little bit later into this presentation. So why are strokes considered to be medical emergencies? As noted in the previous slide, there is a high possibility of death or long-term disability if a stroke occurs. And every hour a stroke goes untreated, the brain ages by 3.5 years, so exponentially aging every minute that passes. Stroke therapies are time sensitive. The sooner you get to the hospital, the more treatment options are available to you. We'll delve into what those treatment options look like a little bit later in this presentation. Strokes can cause other medical complications such as seizures, spasticity of the muscles, migraines, depression, and the list goes on. And 10 to 20% of patients have recurrent strokes within 3 to 4 months after a minor stroke or TIA. So let's delve in a little bit further to what is a stroke versus what is a TIA. So a little bit about the history. The term stroke was first used in 1599, and strokes were initially considered to be an act of God. The lightning bolt is often used to represent a stroke. It's Something that comes without warning can come out of nowhere, hence the name. And the hallmark features of a stroke are the sudden onset of neurologic symptoms, typically affecting one side of the body, or what we often refer to as unilateral. So what is a stroke and what is a TIA? So a stroke is an abrupt interruption in the blood supply to the brain, spinal cord, or the eye. This leads to the acute onset of focal neurologic deficits or symptoms that persist for greater than 24 hours. A TIA, what that stands for is transient ischemic attack, is an abrupt interruption in the blood supply to the brain, spinal cord, or the eye. This again leads to acute onset of focal neurologic deficits or symptoms, though these completely resolve within a 24-hour time period, often much sooner than that, typically within just a few hours. TIA has commonly been referred to in the community as a mini stroke, though I think many of us would prefer that to be thought of as a threatened stroke. This is something that can be considered a warning sign of a larger event that may occur, which is why even if someone were to experience these brief symptoms, it is very important to seek emergency evaluation and have prompt follow-up with both your primary care provider and your neurologist to address risk factors and prevent a stroke from occurring in the future. Many of you have likely seen many of these acronyms appear in various forms of social media or on television over the years. So looking at the most common signs and symptoms of a stroke or a TIA. It's important to remember that these symptoms all have an acute onset, so acute or sudden. Also that they are unilateral, or what we consider focal, meaning they're happening often on one side of the body. The acronym has been updated over the years and now is what we refer to as BFAST. So BFAST stands for B for balance. If someone has a sudden loss of balance or coordination. Eyes, suddenly losing vision, losing partial or peripheral vision, or having double vision. Face, having sudden drooping of the face. Does their face look uneven from one side to the next? Arms, is one arm weak or numb? And this can also be applied to the legs. Is one leg weak or numb? Speech, has someone suddenly developed slurred speech or difficulty producing speech or seem confused? They're not understanding what is being said to them. And T stands for time. Immediately, once these symptoms are appreciated, 911 should be called and prompt emergency evaluation should be received. The quicker you get to an emergency room, the faster we're able to assess you and hopefully give you the necessary treatment to reduce potential long-term deficits that can be associated with a stroke. And just some additional graphics emphasizing what I just said. T, this time is brain. Getting to the emergency room as quickly as you can if any of these signs or symptoms were noted is of most importance. If time is lost, that equates to more brain that is lost, which often results in a higher level of disability that is long-term or even death. And just to further reiterate that, 2 million brain cells can die every minute, increasing the risk of permanent brain damage, disability, or death. That's why treatment within 3 to 4.5 hours increases the chance of a full recovery, or at least resulting in little to no disability.
So now we're going to talk about the different types of stroke. So they can fall into two broad categories. There's ischemic stroke and hemorrhagic stroke. And ischemic stroke is really just a fancy way of saying that there's a blockage in one of the blood vessels preventing the flow of oxygen-rich blood to that part of the brain. So there is either a clot or plaque from cholesterol blocking the blood vessel. Blood can't flow past it, and so the tissue past the blockage is affected. Hemorrhagic stroke refers to a stroke where instead of blocking the blood vessel, you rupture the blood vessel, and as a result, blood starts pouring into the brain. Ischemic strokes account for about 85% of the strokes that we see, hemorrhagic strokes about 15%. And when we see a hemorrhagic stroke, our primary concern is, does this patient have uncontrolled hypertension, which is one of the leading risk factors for this type of stroke. So let's look at different causes of ischemic stroke. So here are 3 different scenarios. So if you think of A simple way of sort of breaking down ischemic strokes or blockages in the blood vessel, if you think of your brain as a neighborhood, you have different parts doing different things, and the pipeline, the water pipes are the blood vessels that take water or oxygen-rich blood to that part of the brain. If there is a blockage at the first house, then the third house down the street is not going to get any water. And that's exactly how your brain works. Similarly, if there's a ruptured water pipe at the first house, then the house at the third house on the street is not going to get any water delivered to it. And similarly, that's how the vascular system is set up. So in the first case, you can have a local blockage. So there's a buildup of plaque or a clot. Usually we see that in the carotid arteries, which are the large arteries in the neck. With time and age, you can get cholesterol buildup, and that artery can get narrower and narrower until it starts causing problems where it could completely close. You can also have the situation where you get an emboli or a clot that was formed in another part of the body, and the organ that's usually the culprit in this case is the heart. You can have a clot sitting in the heart, piece of that clot can then break off and travel up to the brain, getting stuck in one of the arteries in the brain, and so you can't deliver blood to the part of the brain after the blockage. And then lastly, you can actually get a stroke if your blood pressure gets too low. We typically see these types of strokes in patients who are having surgery. If you have a history of hypertension, and let's say your blood pressure, the top number is usually in the 150s, and you're fine with that. But while you're doing surgery for the first time in many years, your blood pressure is normalized to 120. That top number is now 120 instead of your usual 150. You could actually decrease delivery of blood to that part of the brain, resulting in a special type of stroke that we call a watershed infarct. In terms of hemorrhagic stroke, this can fall into two large categories. You can have a rupture of an aneurysm and you get a subarachnoid hemorrhage. Patients who have this type of stroke usually report of a sudden onset of the worst headache of their life. It's a headache that sort of takes your breath away, comes on quickly, and if that ever happens, they should seek prompt medical attention. And the other type is what we call just an intracerebral hemorrhage, usually in the deep parts of the brain, and this is what we see in patients with uncontrolled hypertension. Though these are arteries, they're small arteries, and so they're not designed to handle high blood pressure. Normal blood pressure, the top number is 120, the bottom number is usually 80. In patients who have hemorrhagic strokes, I've seen blood pressures as high as 235, so they're way above normal. These small arteries cannot tolerate those high blood pressures, and as a result, they rupture, leading to bleeding into the brain. When someone comes in with a TIA, we can actually stratify their risk of having a stroke. And this is done by something called an ABCD2 score. This is a scale that takes into consideration several components of a person's health that's important to us determining whether or not they're at risk for having a stroke. We look at age, blood pressure, what symptoms did they have that made us think that they were having a stroke, how long did these symptoms last, and whether or not they have a history of diabetes. After your ABCD2 score is calculated, you can fall into three different categories. You can either be what we call a low risk, this could be a low risk TIA, a moderate risk, or high risk. And this tells us what are your chances of having a stroke within 2 days, 7, and 90 days. And depending on which category you fall into will then help us determine what medication you should be started on. So now what happens when you have a stroke? So you come into the emergency room, you're usually met by the ED physician and the nurses in the triage, and they do the initial assessment. And if they do see focal deficits or symptoms suggestive of a stroke, they will then page the neurologist, and they will actually page and activate what we call the stroke team. So that comprises of the neurology, that's the neurologist attending, the residents usually participate. We also get the pharmacist, the CT techs, who are the ones who actually operate the CT scanners. They're made aware that there's a patient with a potential stroke. So it's almost like shutting things down because this patient is now made a priority. We go ahead and we draw labs because we need to see what's happening in terms of do we think this is a clotting issue going on? Do we think you're losing blood and not supplying the brain with enough oxygen-rich blood? Is this a glucose problem? And after the initial assessment, you're then taken to the CT scanner for what we call a level 1 stat CT. This imaging study takes about 3 minutes to get done. And one of the questions that we often get from patients and their families is, why don't we do an MRI? MRI scans are typically not available at many smaller hospitals. Also, an MRI scan for the purposes of a stroke can take as much as 25 to 45 minutes. And if someone's bleeding in the brain, or if there's a blockage, we really want to intervene quickly. The CT scan takes about 3 minutes from start to finish, so it's really the best imaging modality to be done. The other thing that the CT scan helps us distinguish is whether or not this stroke is caused because there's a blockage or if there's blood in the brain. So this is what the CT scan can look like. On the left, you have someone who's coming in with a stroke, and if their brain looks like this, there's no evidence of blood. Blood in the brain looks bright white, and so the image on the right, that person's having a hemorrhagic event. There's blood pooling in the brain. And so the treatment that we use for stroke patients, which is something called TNK or TPA, that's a very powerful blood thinner. So if you already have blood in the brain, giving you that medication can actually make things worse. In addition, patients who have blood in the brain, we really want to control that blood pressure very well. Okay, and so if they come in and their blood pressures are in the 180s, you want to start working, giving them medications to bring that blood pressure down to at least less than 140. The patient on the left who's having a stroke, we don't see any evidence of blood. And if they don't have any other medical conditions that would prohibit them from getting treatment with TPA or TNK, this patient will actually be a good candidate for intervention with that powerful blood thinner that I spoke about. It's also really important to know when someone comes in with an acute stroke or a stroke that just happened, we really want to keep that blood pressure up. The body's natural response is to crank the blood pressure up. And if they are in fact a candidate for TPA or TNK, we would let that number go as high as 180. We don't want it to go any higher if they get treated. If they're not a candidate for TPA or TNK, that top number in the blood pressure, we would let it rise as high as 220 because we want to keep the blood pressure high so we can get it high enough to push past the blockage and keep that tissue alive. So what is TPA or TNK? So TPA has been used for many, many years, and recently there is a switch to TNK. It's because that TNK can be given a lot quicker. It can be given at the bedside. So here at UVA, we have TNK stocked on all of the floors in the hospital. When there is a stroke alert, the pharmacist actually shows up with the medication. We don't need to pre-mix. We can actually just draw it up at the bedside and give it to the patient. Both of them are powerful clot-busting medications, and the goal is to break up the blockage that's causing the stroke. The primary risk of taking this medication is that it can cause spontaneous bleeding into the brain or any other part of the body. So prior to giving this medication, we often have to ask patients about surgical history, that they have any recent procedures, because if we do, and this medication starts thinning the blood, we don't want them bleeding into a recent surgery site. If it's given pretty quickly, this whole process, even though we're spending time going through the various steps, it's almost like organized chaos. This happens very quickly. Within less than 30 minutes, the patient is evaluated, imaged, and the decision is made to treat. And the reason that we do that is that a lot of our patients can actually benefit from this medication by having complete resolution of their deficits or very little deficits. And the key to this is you can qualify for this medication if you show up 4.5 hours of stroke onset. So when you start developing, or your loved ones start developing, the signs and symptoms of a stroke, as Keri pointed out before, you really want to come to the hospital. This is not the time to take a nap or call your primary doctor or consult with anyone else. The sooner you get here, the more options are available. I can't tell you and stress how many times patients have shown up the symptoms started at 8 o'clock, but they waited till after lunch because things weren't getting any better. And though they did, in fact, oftentimes were having a stroke, they could not be treated with the medication because they were outside of that 4.5-hour window. So all strokes are not created equal. So these are two examples of someone who did, in fact, have an ischemic stroke or blockage, but they were not candidates for TPA or TNK. So if we scan the brain and we notice that we can actually see evidence of stroke or infarct, especially if it's involving a large territory, giving that person TPA or TNK can actually be quite dangerous, because now we're thinning the blood in a brain that has evidence of damage, and now the damaged area is prone to bleeding. So we really, though it's ischemic, though they may have shown up within the time window, they would not be a candidate for any intervention, at least in terms of thrombolytics. So this is just another schematic that sort of brings home and reinforces what we talked about. So the CT scan, as I said before, will help us determine, is there blood in the brain or is there a blockage? We can give TNK if you're within the 4.5-hour window and there are no other medical contraindications. And the other scan that we do is called a CTA. A CTA looks at the actual blood vessels. So the CT scan looks at the brain tissue, the CTA looks at the blood vessels. And the CTA can actually show us whether there is a blockage in one of the large blood vessels. So on this next slide we have here, this is what your blood vessels look like on a CTA. So you give the patient the contrast, it's given IV, and the blood vessels light up on the scans. And as you can see by the arrows indicated, you have bright white, but then it abruptly stops. And the reason it stops is because there's a clot that's sitting there. If there's a clot in one of the large blood vessels, then we can actually have you evaluated by the neurosurgery team, and they can use their instruments to go in and retrieve that clot and hopefully restore blood flow to that part of the brain. The reason that we say it has to be a large vessel is because their instruments cannot get into the smaller vessels. So if we see a large vessel occlusion, we can have you evaluated by the surgery team, and they go through either the artery in your leg, in your thigh, or in your wrist, and they can pass their wires up. This does not involve any sort of brain surgery. We're not cutting into the scalp, the skull. It's all through the blood vessels. They pass their wires through, they can get to the clot and retrieve it. So what happens here is it's sort of outlined on this slide. The catheter goes through, and the goal is to get the clot and remove it. This intervention is good for patients who had symptom onset within the last 24 hours. But the caveat again is doing the imaging. If we see that though you're within the window, but there's already a lot of damage to the brain, removing that clot can actually be dangerous, because now we're introducing blood into a part of the brain that we have evidence on either a CT scan or an MRI that has significant damage to it. So it's a matter of really stopping, looking at your symptoms, looking at the whole person, not just the imaging, and seeing whether or not this person is a good candidate for either TNK, thrombectomy, or there are cases where we offer both. So you will come in, you have deficits that suggest that you're having a stroke, you're within the window for the clot buster, we'll give it to you. We see that there is a blockage on your CTA, we'll call the neurosurgery team up, they'll give the green light, and then you get taken straight to the OR to get that thrombectomy and that clot removed. In terms of hemorrhagic strokes, there are several options available. Some patients do have blood in the brain, and we need to remove that blood because it's compressing on other important structures in the brain. So it's just a matter of removing the blood. There are times we actually need to remove the skull and relieve that pressure. The skull is a fixed space, and if you're pouring blood into a fixed space, after a while, things start getting squished and moved around and pushed into places they should not be. And so then our neurosurgery colleagues will go in and remove the skull and relieve that pressure. And there are times you can actually qualify for clipping or coiling, where they go in, they find where the clot or the aneurysm or the bleed is happening, and they close off that access point to prevent any further introduction of blood into the brain. So these are just two examples of what blood in the brain looks like. The person on the right has a subacute intracerebral hemorrhage, and the person on the left has a small area of blood on the right side of the brain.
So now we'll transition into talking about stroke risk factors. So what can we do as individuals to better protect ourselves from having a stroke and reduce our risk? So there are some things called non-modifiable risk factors that we cannot change. We can't take a medication, we can't change our lifestyle. These things are fixed. So certain things that increase our stroke risk that are non-modifiable include our increasing age. So for every decade we age, our stroke risk does increase. Our race. Studies have shown that African Americans have a 60% greater risk of having a stroke. They do suffer more disability, and they're nearly twice as likely to die from a stroke. Our genetics and family history are also something that we cannot change. And having a previous stroke or TIA also increases the risk of having another event by 10-fold. So modifiable risk factors are things that we can change, whether that's through diet and lifestyle changes or through the use of medications. And these include high blood pressure, diabetes, high cholesterol, heart disease, atrial fibrillation or an abnormal heart rhythm, cancer, obesity and physical inactivity, cigarette smoking, excessive alcohol consumption, and illegal drug use. So I'm going to delve into each of these a little bit further to talk about what they are and what we can do to reduce our risk and better control these factors. So first is high blood pressure, a commonly talked about risk factor that we've already touched on a little bit during this presentation. But high blood pressure is when the force of blood flowing through your blood vessels is consistently too high. The top or larger number is known as the systolic pressure, and it's pressure when the heart beats. And the bottom or smaller number, known as the diastolic pressure, is the pressure when the heart rests between beats. Often high blood pressure does not present with physical signs and symptoms, which is why it can be so dangerous. There are many individuals who may not be able to seek appropriate primary care evaluation and may be walking around with very high blood pressures, which unfortunately we see very commonly. So this is a graphic provided by the American Heart and Stroke Association that breaks down what's considered normal, elevated, and as well as high blood pressure in various stages, stage 1, stage 2, and then what's considered a hypertensive crisis. What's considered normal, I think this number has been around for quite a while, is less than 120 over less than 180, or excuse me, over less than 80. As those numbers continue to get higher, that's when you fall into these other categories. Oftentimes, if you're presenting to a primary care provider or another practitioner, they will often be tracking these numbers. And if this continues to occur, medications are likely to be introduced, as well as discussions surrounding diet and lifestyle changes. So in addition to that helpful guide, the American Heart Association also has these helpful educational tools on their website. So this graphic here shows how to properly measure blood pressure. I think, you know, when someone says monitor your blood pressure, it sounds very simple, though there are things that we do that can actually interfere with those results. So it's very important when checking your blood pressure through either a wrist cuff or an upper arm cuff, that you are keeping both of your feet flat on the floor during that assessment. You want to sit in a relaxed position and try to have that arm that has the cuff on it at a height that is near heart level. We don't want you to be talking during this assessment. We want you to, again, to be relaxed. And if you are checking your blood pressure on a regular basis at home, it's important to try to monitor around the same time every day. That helps to better assess trends and determine if medications need to be introduced or modified. Another thing you can find on the American Heart Association website is this log. Some people still prefer to use a pen and paper to track their blood pressures, though certainly using your cell phone, the Notes app, or other various forms of technology to track your blood pressure is really helpful. We want you to bring these numbers to your appointments because, again, it helps us to see how things are controlled when you're in your normal daily routines and helps guide medication changes in the future. So next risk factor we'll talk about is diabetes. So there are two types of diabetes. Type 1 develops when the body's immune system attacks and destroys cells in the pancreas that make insulin. So this is often diabetes that has onset younger in life, and these individuals rely on insulin for control. And there's also type 2. So this develops when the body develops insulin resistance over time and cannot efficiently use the insulin it makes, or the pancreas gradually loses its capacity to produce insulin. Diabetes is associated with many complications if left uncontrolled. This includes damage to the heart, blood vessels, nerves, resulting in something called neuropathy. Your kidneys, your eyes, your feet can also result in osteoporosis, which is bone loss, or dementia. So high cholesterol is another risk factor. Cholesterol is a waxy substance that circulates in our blood. Not all cholesterol is bad, but if we develop too much of it, it can pose problems to our health. Cholesterol can join other substances to form a thick, hard deposit on the inside of our arteries, narrowing that artery and making them less flexible. The term we refer to this as is atherosclerosis. So the different types of cholesterol that you've probably seen when you've had routine lab work done is your LDL. This is often referred to as bad or lousy cholesterol. This is what contributes to fatty buildup in blood vessels. Alternatively, there's HDL, which is good cholesterol. This helps to carry LDL away from arteries and back to the liver, where it is broken down and passed from the body. And then we have triglycerides. This is the most common type of fat in the body, and it stores excess energy from your diet. So with cholesterol, certainly our diet and lifestyle choices are very important in controlling these values, though family history often comes into play with having high values when lab results are assessed. This is where medications can be emphasized, whether that's using statin medications, pairing statin medications with a medication called Zetia, or even newer alternative medications to those that may have developed statin intolerance over the years. A common one that we turn to these days, if that's necessary, is called Repatha, and that's a biweekly injectable medication that can really help to lower that LDL cholesterol while also avoiding some of those side effects that statins can present for certain individuals, particularly that muscle cramping and pain. So we'll spend a few slides here talking about atrial fibrillation. So atrial fibrillation is a quivering or irregular heartbeat, what's commonly referred to as an arrhythmia, that can lead to blood clots and subsequent strokes. At least 2.7 million Americans are living with atrial fibrillation, which is quite a lot. And about 15 to 20% of people who experience an ischemic stroke have underlying atrial fibrillation, whether that is known to be in existence prior to the stroke or it's first diagnosed when someone presents to the hospital. Atrial fibrillation can be very difficult to detect without heart monitoring, as most individuals don't notice any symptoms, though there are few that will notice a rapid or irregular heartbeat, fluttering in their chest, dizziness, shortness of breath, or fatigue with exercise. So it's certainly encouraged that if one were to be experiencing any of those symptoms, you seek advice from your family practitioner as soon as you can. Atrial fibrillation is treated with blood thinning medications and often with heart rate controlling medications as well. So this is just a graphic to show kind of what is happening when AFib occurs. So in normal electrical conduction of the heart, you have your sinoatrial node here at the top that's sending normal electrical signals throughout the heart into the atria. And then in this graphic that shows atrial fibrillation, there's really disorganized electrical signals being sent out. So that causes those top two chambers of the heart to quiver, and that allows blood to pool there. Unfortunately, clots can form, and those can leave the heart with subsequent beats. So there are types of atrial fibrillation. So persistent means it's always present. And paroxysmal, which is often more common, is a type of atrial fibrillation that comes and goes, meaning that you're only in this rhythm for sometimes mere seconds, minutes, or hours before you convert back to a normal rate and rhythm. All stroke patients, once they're admitted to the hospital, will remain on heart monitoring while they're here to screen for atrial fibrillation. And if there's a high suspicion for it and we don't detect it while you're here in the hospital, we place what's called a 30-day monitor. We often refer to them as 30-day MCOTs. This allows to track your heart rate and rhythm over a 30-day period, often when you've returned home or you're participating in rehab therapies, which may cause atrial fibrillation to occur, and thus we can change our plan of care and change medications. We do have a score that we rely on called the CHADS-VASc score, which looks at the risk of stroke occurrence in patients with a history of AFib. And on the next slide, I'll delve into that score a little bit more. If after use of that 30-day monitor, we don't detect any atrial fibrillation, but we're still quite suspicious for it, we can turn to a device called a link, or sometimes referred to a loop device. This is a device seen in this picture here at the top corner that looks, it's only about the size of a clip of a pen, and it's inserted beneath the skin on the left side of your chest. This is an implantable device that can provide continuous monitoring for up to 3 years. And you typically do remote transmissions to your cardiologist, usually once a month, to determine if any atrial fibrillation episodes have occurred. And while there's procedures called ablation or cardioversions that can treat atrial fibrillation, kind of kick someone out of that rhythm, if you will, it is not a definitive cure for atrial fibrillation. Atrial fibrillation can come back in subsequent days, weeks, or even years after undergoing an ablation or a cardioversion, which is why it's very important to remain on blood thinners even after undergoing these procedures. So touching on that score I mentioned, so it's looking at the risk of stroke occurrence in patients with a history of AFib. So there's many things that are factored into this score, particularly looking at your history. Do you have a history of congestive heart failure, hypertension, a history of diabetes, prior stroke or TIA, or vascular disease? What is your age? Over age 75 gives 2 points, age 65 to 74 is 1, and female sex also gets 1 point. So the higher you score on this, the higher you score here puts you at a higher risk for stroke due to atrial fibrillation, certainly prompting the use of blood thinners immediately. So switching gears just a little bit, looking at additional risk factors, so cigarette smoking and alcohol use. I think over the years, we've all learned that cigarette smoking offers no health benefits and certainly puts you at a high risk of stroke. This is often due to developing plaque within the blood vessels, or that atherosclerotic disease I mentioned. And certainly excessive alcohol intake also increases that risk as well, thus increasing your risk of stroke. I believe a resource was put into the chat. So if you're in the state of Virginia, there's resources through the Virginia Department of Health that can assist with quitting smoking. Research has shown that not only do medications to assist with quitting, such as nicotine patches or some of the oral medications that are utilized, in addition to counseling, are two things that, when paired together, offer very high success rates when someone is wanting to quit. Next, we have obstructive sleep apnea, or the term OSA. So all patients are screened for obstructive sleep apnea pretty much when you enter the hospital for whatever reason, but certainly if you are on the stroke service. The screening is even more important if someone is reporting snoring while sleeping, excessive daytime sleepiness or fatigue, or witnessed apneic episodes. So are there witness periods while they're sleeping where they appear to not be breathing? Sometimes that can be hard to determine if someone is sleeping alone, though certainly if they have a spouse or a partner, that can be helpful in garnering that information. Whether they screen positive at the hospital or these symptoms are reported, sleep studies can be scheduled. And if they are proven to have obstructive sleep apnea, they can assist with mask fitting to help improve compliance. Sorry, the light went out. Assist with mask fittings to improve compliance, because having controlled obstructive sleep apnea not only can reduce your stroke risk, but it also helps to improve blood pressure control as well. Lifestyle. So diet, a good diet, one to follow to help reduce your stroke risk, focuses on low carbohydrate and low fat intake. The diet that wins out year after year after year is the Mediterranean diet, really for reducing various health diagnoses. The Mediterranean diet focuses on having many lean proteins, so that includes chicken, turkey, fish, leafy greens, vegetables, beans, and of course, still incorporating some fruits. Red meat should be consumed in limited quantities as well. And then, of course, having proper hydration. Energy drinks can certainly lead to elevations in blood pressure and elevations in heart rate, which is something we want to avoid. So that should be something that's you talk to about with your primary care provider if that's something that you frequently consume. And then in terms of exercise, what's currently recommended by the American Heart and American Stroke Association is at least 30 minutes a day, 4 times a week of cardiovascular exercise. So that's exercise that raises your heart rate and causes you to break a bit of a sweat. That can be going for walks around your neighborhood, on a treadmill, or running, spinning, you name it. But trying to be as active as you can within reason certainly goes a long way to reduce your risk. And cancer. So you may think, well, how is cancer a modifiable risk factor? Well, certainly if cancer is diagnosed and initiating treatment is something that can help. But cancer puts the body in a hypercoagulable state, which means that these individuals that are at a higher risk of developing blood clots. Certain cancers have a higher risk of this happening. And oftentimes your cancer providers, as well as neurologists or primary care physicians, are all in discussions about how to best manage that risk. There are also certain types of cancers that are known to metastasize or spread to the brain. And that includes lung, breast, melanoma or skin cancer, renal cancer, which is kidney cancer, and colorectal cancer, with melanoma and renal being associated with a higher risk of bleeding or problems within the brain from those metastases. So the hallmark of stroke prevention is risk factor management. That's why it's so important, and I know I've stressed this several times already, but to have regular check-ins with a primary care provider. Primary prevention is the best method to reduce your risk of something like a stroke happening. So staying on top of blood work and important dietary and lifestyle modifications that you need to make is your best bet at reducing your lifetime risk.
Okay, and now we'll talk about some genetic disorders and stroke syndromes. And this is just a slide that highlights some of the common stroke syndromes or genetic disorders where stroke is part of the disease process. The first one is moyamoya. This is where you get narrowing of the blood vessels in the head. You see this in young patients who come in with their first time stroke. They usually don't have any stroke risk factors. And when we do the CTA, we actually see a very unique pattern called a puff of smoke. So what happens is as that contrast is running through the blood vessels, instead of seeing a nice clean line, you actually it looks like the vessel is smoking. And that tells you that it's a sign that moyamoya may be happening. There's a medication, there's a disease called CADASIL. It's caused by mutation in the Notch3 gene. And the hallmark of that is migraine, strokes, and dementia. So this is the patient that comes in and tells you that they have aunts and uncles who develop dementia at a relatively young age. They have a history of migraines. And then when you scan their brain, in addition to seeing strokes, the anterior part or the front part of the temporal lobes in the brain tend to light up really well. And so that's CADASIL. The third is one called Fabry's disease. This is the disease that's actually a genetic disorder. It's caused by a mutation. It's an X-linked mutation. And these patients develop kidney disease. They have a lot of neuropathic pain, can even have skin lesions. They get it in young adulthood. And then as they get older, strokes become part of the problem. And they really require an interdisciplinary approach to managing this condition because it affects so many different organ systems. Next, we have, in terms of stroke management, all stroke patients, if you had an ischemic stroke, we put you on an aspirin unless it's contraindicated. And it's important to know about 20 to 30% of patients do not respond to aspirin. So alternative antiplatelet medications like Plavix or clopidogrel or ticagrelor can be used to inactivate those platelets and reduce your chances of a stroke. Cerebral amyloid angiopathy, I just wanted to briefly touch on this. And this is where you get these microhemorrhages on the brain. So when you look at the MRI scan, it almost looks like someone spilled little black M&Ms onto the brain. And these are tiny bleeds. They usually don't cause a problem. We see this usually after the age of 55. These patients, if you do have CAA, should not be started on an antiplatelet like aspirin or any blood thinners unless there's a conversation with neurology. We do understand that certain cardiac conditions require antiplatelet therapy, and so we need to have that discussion that if you have any sort of neurological deficits, you need to be brought in to make sure one of these tiny bleeds did not blossom into a larger bleed.
I'm going to skip ahead a few slides here just to make sure we have enough time. I want to make sure we are able to talk about a few additional things within the time frame.
Sure, and let's briefly talk about strokes in young people. As Keri pointed out, risk factors for strokes are high blood pressure, diabetes, high cholesterol, is what we typically see in older patients. Younger patients, they've just not been alive long enough for these chronic conditions to really have a systemic effect on their blood vessels. However, in young people, they do have strokes. Their presentation can be different. They can complain of things like sudden onset of confusion, and often is misdiagnosed for drug abuse when it really isn't. They may in fact be having a stroke, acute hearing loss, headaches that are different from their typical headaches. And the next slide shows an image of a very important artery. It's called the artery of Adamkowitz. We see this in patients who use illicit substances. You can actually get vasospasm in this artery, and instead of getting a stroke in the brain, you actually stroke the spinal cord, leaving you with severe deficits. I have a 23-year-old who used illicit substances. Her legs felt funny, woke up the next day, had loss of her legs, is now needing a catheter, help with bowel regimens, all the rest, because she stroked her spinal cord. In addition, there are activities that younger people tend to participate in. So roller coasters, the jerking of the roller coaster can actually cause you to stretch the blood vessels in the neck, and you can get a stroke. Manipulation by chiropractors, even going to the hair salon. And some people, if you tilt their heads back too aggressively, can actually rupture one of those blood vessels and lead to a stroke. There is something called RCBS, and we're briefly going to touch on this. This is typically seen in patients who are started on new medications for antidepressants, for depression, or if they use energy drinks. A lot of these energy drinks can actually cause this. And this is where you get the blood vessels in the brain spasming, cuts off the blood supply, they get a stroke. The important thing is that this is usually a reversible process. So we can image them after a 3-month period, and we see that the blood vessels actually relax. But they come in with a sudden onset of a headache that leaves them confused and can sometimes even present with seizures. So stroke prevention in the young, there's something called a Roach score where we see whether or not, so part of the stroke workup, we actually look at the heart and we see if there's a hole in the heart. Everyone has this hole at birth, but over the first few days and weeks of life, that hole closes. But in a certain percentage of patients, that does not happen. And if that hole remains open or patent, that can actually increase your risk of having a stroke, and could be a heralding sign if they do have a stroke, whether or not there's an underlying clotting disorder. Also, in women who have first trimester miscarriages, they should be evaluated by a hematologist to make sure that they don't have an undiagnosed clotting disorder that would present itself only when they're pregnant.
So now looking at some complications of stroke. So we know about the physical complications of unilateral weakness, facial weakness, speech, and visual deficits, but stroke can also result in various other complications. Mood complications are quite common. 40 to 50% of individuals who have a stroke will develop post-stroke depression, post-stroke anxiety disorders, or other mood abnormalities that have to be addressed. We address these during someone's inpatient stay, as well as routinely in the outpatient setting, and to ensure that we are appropriately addressing this if it develops. Seizures, cognitive dysfunction, so resulting in things like short-term memory loss or prolonged confusion. Spasticity, so a tightening of those muscles on the side that is weak. This can result in significant pain and difficulties furthering your recovery, right, regaining strength. Various pain syndromes, depending on where the stroke occurred. Increased fatigue, called post-stroke fatigue. So it's a very low energy, even despite getting good night rest that can persist for several months, even years, as well as personality changes, depending on where the stroke occurs. and looking at life after a stroke. So whenever anyone is in the hospital with a stroke, you are assessed by our therapy colleagues. This helps to determine your level of needs once you leave the hospital. I would say the vast majority of folks will either begin to receive outpatient or home health therapy once they leave, meaning they're receiving either physical, occupational, or speech therapy, or sometimes all three, various times throughout the week in order to help them regain physical recovery and physical independence. Certain individuals do require an acute inpatient rehab stay, meaning you're in a facility for several weeks to gain improved function, or skilled nursing facilities, which is a longer length of stay. And there are various resources and adaptive equipment that can be sought out if deficits were to persist. So things that can help you return to independence despite not fully regaining your strength. There are also various stroke support groups. I encourage you to look at the American Heart and Stroke Association. They have a list of resources available for groups that may be located in your area. So I think we were cutting it close, but I know we have some questions here, but I think it's important to know that
there is life after a stroke. It looks different, but one of the things we stress here at the UVA Stroke Clinic is that you are not your stroke. You've had a stroke, but there's still a lot life left and a lot for you to do, and ways for you to engage with people in your community, your family, and your friends. Also to remember to give yourself grace for the journey. Every day is not going to be a good day. There are some days that are going to be more challenging than others, but to celebrate the small victories. And sometimes you just need to take a deep breath and say, you know what, today didn't go well. I'm having a bad day. We'll restart tomorrow. And an important thing for family and friends of patients who suffered a stroke is to offer help to them in a way that's meaningful. So just outright helping them may cause them to feel like they're not making the necessary improvements, or they're a burden to others. And so stopping and asking them, what can I do to help you? So they can let you know what areas they do need help in, so your help can be received and perceived as help, and not just you thinking they're incapable. And then maximizing your time with your doctor. A lot of time you go to the doctor's appointment and you just have 15, 20 minutes. I always say, write down a list of your 3 important things that you want discussed, bring it to their attention. They may only get to the one thing on that list, but at least it's a start, and they are aware of what are the things that are concerning to you.
So now we'll stop sharing and turn it back to Susan to go over some questions.
Great. Thank you so much for that comprehensive presentation. That was wonderful. We could have time for a few quick questions. One question that came in during the registration process was, do brain cells heal over time that have been involved in a small stroke?
So brain cells do heal, but they do not go back to functioning the way they did prior to the stroke. Think of a stroke as a bruise. The same way you bruise your skin, you can always see that scar that something happened. Similarly, when we scan your brain after a stroke, we can actually see evidence of an old stroke on the brain. So while they do heal in terms of not necessarily actively causing a problem, there is still radiographic evidence of a stroke. And then the surrounding cells that have also been impacted by the stroke can often serve as a source of seizure activity. So you can get these cells just spontaneously behaving abnormally, causing you to have seizures. That's why seizures is one of the #1 complications of a stroke.
Okay, this question is, is there a link between migraines and strokes? And are you at higher risk of a stroke if you get migraines often?
So there are studies that have shown that there's actually a link between patients who have migraine with aura tend to be at a higher risk of having a stroke. However, I think the hallmark of stroke prevention is really the high blood pressure, your diabetes, your high cholesterol, because what those conditions do, they actually compromise the integrity of the walls of the blood vessel, where you can get your plaques forming, where you can get things narrowing. So really controlling those risk factors. And if you do have a history of migraines, talking again to your primary care doctor or your neurologist, because there are certain medications that are used to treat migraine that should be avoided in stroke patients or patients who are at risk for having strokes.
Okay, thank you. Are strokes on the rise in the US, and if so, why?
Yes, strokes are on the rise in the US and globally, really. And this goes back to all of those risk factors that we talked about. Seeking primary care these days, especially as a result of the pandemic, has certainly been challenging, or it certainly has exacerbated pre-existing issues within the healthcare system. But because of that, many risk factors have gone uncontrolled or unaddressed, which in turn has raised the occurrence rate of strokes both here in the United States and globally.
Okay, another question. Do strokes in the brainstem have different symptoms from other strokes? And is the recovery process different than a typical stroke?
Yes, so strokes in the brainstem do present differently. If you think of the brain cells as balloons on a string, so the brain has the balloons and the strings all sort of come together in the brainstem. So in a brainstem, a very small stroke in the brainstem can actually leave you with a lot of deficits. In addition to having difficulty moving or feeling things on one side of the body, brainstem strokes, those patients also struggle with swallowing. So those are the patients who may need feeding tubes or PEG tubes, which are tubes placed in the stomach to help introduce nutrients and medication. So they tend to have a more complex course because simple things like swallowing, controlling their saliva, taking in medication and food now becomes a problem.
Thank you. Is it true, this is another question, is it true that all improvement post-stroke happens within a year of the incident and that further improvement is not likely?
So commonly what we refer, I think when we're speaking to our patients following a stroke, is that the largest portion of recovery we'll tend to see within those first 3 months, which is why we try to get individuals into rehab programs or therapy services immediately. It doesn't mean that once someone reaches that 3-month or 90-day time frame that all progress stops. It just means that it might move even slower. Each person is different. So some folks do reach that plateau where they're not really seeing progress after 6, 9, or 12 months, though there are certainly many individuals who continue to make small incremental improvements well after a year following a stroke. I think keeping a positive attitude, trying to keep up with exercise and therapy services as long as you can is what affords those individuals that continued improvement, however slight and however small.
And another important point is younger patients tend to do better just because they have age and youth on their side. So I've had patients in their 30s who suffered a stroke and then went on to make a full recovery. So as Keri pointed out, therapy is important, but then really having a good support system and that continued motivation to get better goes a long way.
Thank you. And our last question, does the stroke care team get involved in initiatives to prevent strokes among those that are at risk?
Yes. So here at UVA, we are what's called a comprehensive stroke center. So that's the highest designation from the Joint Commission. And a part of that designation is reaching out to our surrounding communities to provide stroke education and reduce stroke risks. So several of our teammates, our attending colleagues, our research team, nurses, you name it, get involved in various activities, whether that's presenting information at various community events, community fairs, our farmers market that occurs on the weekends. I myself bi-monthly go to our local food bank and provide education from car to car, and we also do blood pressure risk screening. So we've really been able to expand our reach to not just here in the Charlottesville City and Albemarle County community, but the many surrounding counties that we provide care to. So yes, we are very involved and we're always looking to become more involved. So if there's something that you'd like us to attend, certainly let us know.
Well, thank you so much. That was an incredible presentation, very comprehensive, as I mentioned. I want to thank both of you for your time today. I know that you're both very busy and I appreciate your time today. So thank you so much.
Thank you so much for having us.
So thank you again to Dr. Roach and Ms. Johnson for sharing your knowledge and your expertise with us and with this comprehensive presentation. As we can all see, UVA is lucky to have such skilled clinicians. As they said, strokes impact hundreds of thousands of people each year, and we appreciate you spending your time this afternoon discussing these risk factors, treatments, and recovery. I want to take a quick moment and bring an upcoming Lifetime Learning program to your attention. If you're in the Richmond area, please consider joining us on Wednesday, November 8th for an evening reception from 5:30 p.m. to 7:30 p.m. at the Black History Museum. Join us for an opportunity to explore the museum's Art of Freedom 2 exhibit and to hear a lecture from UVA's Kevin Gaines, who's the Julian Bond Professor of Civil Rights and Social Justice. To learn more about this program and register, visit our website at engagement.virginia.edu/learn. When you visit our website, you can also check out other Lifetime Learning programs, our podcast library, our Thoughts from the Lawn blogs, and our UVA Speaks podcast series to read, watch, and listen to our expert UVA faculty. So thank you again for joining us for this hour of learning, and I hope you enjoy the rest of your afternoon and evening.